And a very happy good evening to you, my friends. It is that time again, Tuesday at 5 o'clock on the Gulf Coast, which means it's 6 o'clock in the East, 4 o'clock in the mountains, and 3 on the West Coast. And it's time for Fertility with Fink and Friends. I am Fink, you are friends, and this is the place where we get together every Tuesday evening and talk about all those things that are important to us. And that is things about getting a family and making a family and keeping a family and everything there is to know. So it is great to see everybody here tonight. I am Dr. Randy Fink. I'm a fertility gynecologist at New Life Fertility in Pensacola, Florida. We also have offices in Mobile, Alabama, and in Panama City. And I also work at the Missouri Center for Reproductive Medicine, MCRM, which is in St. Louis, also with an office in Tulsa. So happy to consult with you anytime, any place. We do it over the phone. We do it in person. We do whatever you want to do. How's it going tonight? It is a rainy night. It's been a very rainy day on the Gulf Coast today. So I hope your day has been a little bit more sunshiny and that your weekend was great. It is always a challenge to get through a Monday and to go to a Tuesday, but I have to say this is my favorite place to be. So really happy to be here with you and nice to see such friends here joining us tonight. Mrs. Vince from the great state of Kentucky, who says, hello, lovely human, and God bless you. You say such nice things. I appreciate that very much. Hello, Styles family. Good to see you. Tara, nice to see you here as well. What a treat to have you. A special hello this evening to Emily and Harold in Mobile, who are joining us, my parents, who have, I guess, figured out how to turn on the Instagram in order to be able to see the broadcast. We've got Priest Lana over here on this side, and we got a bunch of folks who have joined on the Facebook side of things. So we have some different feeds here. This is Randy Fink MD, my Instagram feed. This is New Life Fertility's Instagram feed right over here, and in the middle we have First Fertility, because we are part of the First Fertility Network. We have MCRM, we have New Life Fertility, we have LinkedIn, we have YouTube, we have every manner of means by which you can join us here tonight. So thanks so much for being here. Hey, you know, it was Pride Week, or it is actually Pride Month. And so we here at New Life Fertility participated in a wonderful event just this past weekend, and that was the Pensacola Pride Festival out at the fairgrounds. We had a nice booth there. We gave out some great little fans for the heat, things to fan yourself, and as well as a lot of good information. Met a lot of really wonderful people, great new friends out there, and we thought it might be very interesting to talk about some of the options that we have for the LGBTQ plus community, different things that we can do to help you with your family. And so let's go over that a little bit now, and see if anything interests you here. So I'll be honest with you, the most exciting thing that I do here as it pertains to same-sex couples is something that's known as reciprocal IVF. And with reciprocal IVF, one partner donates eggs. We stimulate one partner to stimulate the ovaries to be able to get as many eggs as we can get, which we then retrieve from the ovaries. They go to the laboratory where we have donor sperm that fertilize those eggs. We make embryos. And then we take those embryos, or take an embryo, and place it back into the other partner. So one partner is the egg donor and the other partner is the pregnancy carrier. And that's what's known as reciprocal IVF, and is, like I say, I think it is one of the just coolest things that we can do as far as helping folks make a family, because using that science and that technology to be able to get eggs from one person and put those embryos into another is just, I think, honestly, it's really fascinating. But it's also just the coolest thing, because then that baby has the genes from carrier number one, or from a partner number one, and has every blood cell in their body is manufactured. It flows through the mom that's carrying. So that's partner number two. Really neat stuff there. Of course, we have conventional fertilization ways to do things like insemination. Insemination is the act of generally what we do is we give the partner who wants to be pregnant some medication, again, to rev up the ovaries to make sure that the ovary is going to produce at least one egg, and maybe even two, so that we can give sperm a little bit more of a target to hit. The couple selects a sperm donor. We have donor sperm, and we place that sperm inside the uterus at just the right time in order to maximize the odds that sperm and egg shake hands with one another. And that way, conception is taking place inside the body in the standard way that it does. But we're able to use the donor sperm for that. We know that it actually fertilization works better when that sperm is there before the egg is released. So usually what we do is that we've given that medication to rev up the ovaries. We do some ultrasounds, we do some monitoring to see how the egg is growing in the ovaries, or what we call the follicle. And when we see that it has reached a mature size, we give you a trigger shot. And the trigger shot tells the ovary to get ready to release the egg. That trigger shot will cause the release of the egg in about 48 hours. So the ideal timing for the insemination, or the IUI, the intrauterine insemination, is about 24 hours later. So sperm will live inside a female body for about 5 days. So we like the sperm to be there generally about a day before the egg is released. So that sperm is all hanging out, waiting for the egg to come so that it can fertilize it. This is an IUI, or what they call artificial insemination, or intrauterine insemination. And we also have the IVF process, where one partner donates the eggs and carries the pregnancy as well. So what neat stuff we have there. We also have options for male couples. Male couples obviously don't have eggs, and so we can help you to select a donor egg, and then decide on which partner will fertilize that egg. So you provide sperm from one of the partners. That creates embryos that then go back into what we call a gestational carrier. Now, some people used to call that a surrogate. A surrogate, I think of as someone who uses both their eggs and carries the pregnancy. So we call it a gestational carrier. You're selecting a donor egg, you're fertilizing that donor egg, and creating an embryo that then goes back into the gestational carrier, who carries it through the pregnancy, who delivers for you, and then that's your baby. We also have many options that we can do for transgender folks, and of course it becomes very individualized on that basis, but there is still sperm, even if someone the sperm is still there. There is still an egg, and so these are all things that we are able to deal with, and it becomes really so very exciting to be able to help our community, no matter who they are, because as we come to know here during Pride Month, love is love, and all people are welcome in our doors, because when it comes to helping that family get made, doesn't matter who you are, as long as you have that dream in your heart and that twinkle in your eye. That's what we're here to do. So that is the story with that. And if you have questions, please throw them my way. Happy to answer those. And of course, we're always happy to talk with you individually about what your options may be as well. Hi to the one that I can't pronounce, BRN, howdy, and hello to Sheila125. Over here on my Instagram side, oh gosh, we had a bunch of folks join. Claudine for Navy, hello Marlena, hello lovely Onyx, good to see you this evening. Gradle 1013, howdy to Pensacola Wellness. Stephanie, nice to see you here. Alyssa is here. Aaron is here. Hi, Aaron. We've got Martha. And I see over here we have Brienne asking a question from the Facebook side. Brienne says, I'm on my second modified natural embryo transfer. On cycle day 10 monitoring, my lining was 6.8 millimeters, homogeneous. My estradiol was 146, my progesterone 0.25. The LH was about 6. They had me trigger that night and started 2 milligrams of estrase to help the lining. Does it make sense to you to be adding some estrogen at this point? Is it a good or bad idea to have sex during the trigger and before the embryo transfer to try to increase chances? I tested day 6 for BA and have a history of early loss, so I'm just trying to optimize. Oh, I have an untested day 6 for BA. Okay, so here is what I think of that, my friend. So you got a bunch of different things going on. So a modified natural embryo transfer is what happens when we're using an ovulatory cycle. So obviously placing an embryo inside of you, you have to be at the place where that embryo can implant hormonally. And that means that your lining has to be prepared. So what do we do? If we're doing a medicated cycle, we give you a bunch of estrogen to grow that lining, as I like to think of it, as to make a nice, spongy, warm, juicy place for an embryo to implant. And then we give you some progesterone. Progesterone takes that lining, it starts to compact it. Pro-gestation, pro-pregnancy. Progesterone is really the hormone that your body needs in order to get that pregnancy to implant. When we do a modified natural cycle, what we've done there is that we've given you some ovulation induction, and you probably used some letrozole, I would guess. And that letrozole does two things. It drops your estrogen level such that and the way it does that is that it prevents the conversion of your own testosterone into estrogen. So it causes just a little blip of that estrogen level. And what that does is that it tells the brain to make a follicle, because that follicle is where you get your estrogen. And as you make that follicle and that follicle grows, that is what will give you your lining. So instead of using a patch or a pill to build that lining, your own follicle is building that lining for you. Now, I like to see that lining at about 7 millimeters. And so that was probably the rationale to give you a little bit of extra estrogen there so that it could thicken up just a little bit. Really, to be honest with you, if it was measuring at 6.8 millimeters instead of 7 millimeters, I would say that could very easily be just the difference in measurement between, how a tech measured it. Because if that trackball is off, even by just the tiniest, T9cest little bit, that can make a difference between, of 0.2 millimeters. It's a very, very small difference. But I think it's nice to have a little bit of extra leeway there. So I think that's probably why they gave you the extra estrogen. Now, if you use letrozole for ovulation induction, then your estradiol number is going to be suppressed. We know that the optimum estrogen level for an embryo transfer is between 200 and 600. And so, if you weren't on the letrozole, you probably would have been there. So I think that is really probably fine. So I guess they're probably giving you that just to increase your lining a little bit. And so, yeah, I would say that's okay. And that kind of does make some sense. Now, what about sex during a natural cycle transfer? And I would say, yeah, sure, why not? Because what we're after here is after getting you pregnant. Now, let's be honest about that. We really don't want you having twins. We really don't. And people say, but I want to have twins. Well, you know what? I want to get it over with all at once. We don't want you having twins because twins is a high risk situation. And having more than one baby on the inside there increases the risks of the pregnancy to the point where, you know what, it's just not worth it. The risk is not worth the reward there. It may not really improve the overall birth rate. But when you're putting an embryo inside, you just never know what's going to happen. The likelihood of that embryo sticking really has to do with the age at which the egg was taken from you in order to make that embryo. So an active intercourse will naturally put some sperm around that egg. You may get a fertilization there, and at the same time, you may get your embryo to implant. So there is a non-zero chance of a twin pregnancy, just to be aware, and any one embryo can still split and become two. So you just got to know that, yeah, it does increase your risk of multiples. But to my mind, in that scenario, what we really want to do here is to try to get you pregnant. And my presumption is that if you went through IVF to the point where you made some embryos, you were probably having a hard time getting pregnant to begin with. So what are the odds that sperm is going to fertilize that egg in that cycle when you've been having difficulty before? You know, the odds are probably lower. So I'd say, yeah, man, bring it on. Bring it on. Is there such a thing as too much progesterone support? I have a history of endometriosis and adenomyosis and early loss, doing HC boosters as well for the first time. And yep, did use letrozole for 5 days. So that letrozole for 5 days was the reason that your estradiol number is a little lower. So the amount of progesterone you get is really what I would call highly programmed. If we're doing a medicated cycle, then you get 120 hours of progesterone. That puts you in the fertile window, 120 hours plus or minus 3 to be precise. When you're doing the modified natural, if you're transferring a blastocyst, then you are going to do your transfer. If you do a trigger, it's going to be 7 days after the trigger, and that is puts you into that progesterone window. Now, most of the time when I do modified natural transfers, I like for folks to be using some vaginal progesterone as well. Vaginal progesterone will not affect your serum level of progesterone, but it is a local effect just on that uterine lining. And that just makes it a nicer little spot for a pregnancy to implant. So it's not that there is, too much progesterone in that regard, because that's the progesterone that your body naturally makes in order to get you to that place of implantation. Now, let's say, for instance, that you were, you did you ovulated, and then instead of doing it 7 days later, you waited 9 days. I'd say that was too much progesterone. That closed your window. So the timing is very important on when you do that transfer. But as far as, can you get too much progesterone, or is there a progesterone level that's really too high? And we believe the answer to that is no. So we're looking for a progesterone level that is above a 10. Particularly when you're doing that modified natural. Progesterone level above 10 tells me that you made enough progesterone that ought to get you where you're going. Brian, we have our fingers crossed here for you, my friend. Absolutely. And you mentioned one other thing, and that was doing the HCG boosters. There aren't a lot of programs. I see. You're on 3 vaginal, 1 oral, and 50 units of PIO plus HCG boosters. That's a lot of progesterone. Yeah, that is a lot of progesterone. But I'm not sure why you necessarily need the oral one, the vaginal, and you're using PIO as well. So when you do them, all right, now you just confused me, because when you do a modified natural transfer, you're doing that because your own body is making the progesterone and you don't have to use PIO. So not really sure why they're doing that. Now you have created an area of confusion. So, but to answer your question, there's not too much. That's not going to harm anything. It's just it's really overkill, I think, is what's happening there. Okay, so let's see what else. Who is with us? Hello, Angelina. Nice to see you, Foxy, this evening, and into Pinot Journey. And Foxy, I understand that you had a sad day, and I'm sorry to hear that. I never really learned why that was, but I hope that your day has gotten better, my friend. Nothing but smiles coming to you tonight. Let's see who else is with us here. Claudine said hi, and Ruger said hi. Marlena asks, what is the rationale in medicated transfers for using estrogen patches versus pills? So you really can use either. And the data shows us that either way is fine because both of them do the job. What are the original way that this was done was using patches, and the reason for that was because the thinking was that being absorbed through the skin, transdermal absorption, was somehow better for you or more reliable than being absorbed through the mouth, so or through the stomach, because when you take a pill, that pill goes into your stomach. It gets dissolved in your stomach, and the blood supply carries that to your liver. And that's what's known as the first pass effect. The first pass effect. Once it goes to your liver is a big detoxifying organ that lives here in your right upper quadrant. And so you have to have enough medication left over after it's been absorbed in this, broken down in the very highly acidic environment of your stomach, that blood supply carried to your liver, detoxified in your liver, and then enough left over to do what you want for it to do, which in this case is to do what estrogen does for pregnancy, to build that lining. When you do the transdermal approach or a patch, then what's happening is that it doesn't go through the liver. So you get a more reliable and constant serum level of estrogen, right? Because the patch is sitting on the skin and is being absorbed constantly, as opposed to taking a pill and then taking another pill and then taking another pill, when you get, these kind of ups and downs from that pill taking. Now, actually, as it turns out, it doesn't really make a difference. That was the original thinking, that you get better absorption from the transdermal. And so a lot of programs have stuck with that using of a patch because it's just the way it was always done. Does it make a difference? No, it should not in terms of outcomes for most people. There are some people who don't like to take the pill, and there are some people who don't like to use the patch. Personally speaking, I'm not a huge fan of the patch because it can irritate the skin. It leaves adhesive behind on you. You've got like 4 patches stuck to your belly. It may make you feel like you're, getting off a spaceship or something. It doesn't feel entirely natural. Or if you work out a lot, maybe you sweat and the patch has a hard time sticking. So, I like using pills, but again, the old standard was using a patch, and that's really the reason why, only because it was an old standard, and old standards die hard. So let's see what else we got going on here. Hey, Pooey, nice to see you there. Nina Buena, nice to see you. Haven't seen you around for a while. T. Doherty, we've got the fine Ms. Sack here this evening. Nice to see you. What would be the reasons a period of being more than 2 weeks late after a retrieval? I get my period every month. Well, that's interesting. So when you have an egg retrieval, right, you are growing eggs and you're getting a trigger shot. So technically speaking, you're ovulating, even though we don't want you to release those eggs. We're going to retrieve those eggs. And then you form where the space that the egg comes from forms a little cyst in the ovary that's called the corpus luteum. And so that's where you make your progesterone. What triggers a period is that your progesterone level is going here. And then if it sees you're not pregnant, it starts to drop off. And it's that drop off of progesterone that gives you your with what we call withdrawal bleed. That's what gives you your period. Well, so just kind of depending on how many follicles you had and how much corpus luteum you made, that may be the reason that your progesterone level is still high enough that it hasn't dropped off yet and caused that bleed to take place. That would be my kind of best guess in that situation. There are some situations where folks just have a hard time growing a lining because, you got to have a lining there to slough off. If it's going to slough off, if you're going to bleed, something has to come out. But it sounds like if you're otherwise getting a period every month, it's just a little delayed now after the retrieval. Most people after an egg retrieval, it's usually about 10 days or so when they get a period, but sometimes it can be 14 or maybe even 16 days. So I think that's probably what's going on there for you. So I think nothing to worry about. Hey, Chris in Miami, I can't believe you actually joined. Marta, nice to see you. And Chiquita Rivera. Hello, Chiquita Rivera. Over here, Sarah has joined us. And let's see, guess what time it is? It is half past the hour now, which means it's time for us to do a little thing that I call the 5:30 Fuzzies with Fink. The fuzzies with Fink has nothing to do with the amount of facial hair or anything else like that, but the warm and fuzzies, because if you have been through this process of fertility treatment, you know that it is a difficult thing to have to do. It takes its toll on us emotionally. Anxiety can rear its ugly head and really change the way we approach our lives. We can start to feel depressed about decisions that we've made in the past and things that have happened to us. We get fixated and worried over many of those things that are out of our control for the future. But this is what our brain does. It perseverates. It starts going faster and faster and faster. And sometimes it's just really, really hard to shut that down, to silence that noise. And that's really what it is. It's noise. But when we're dealing with these issues, and it's not just about fertility. It can be issues pertaining to family. It can be issues pertaining to loved ones and relationships. It can be issues about school, issues about job and work. All of these things which compile on us to become stressors can make us feel very isolated, can make us feel very much alone. And at this point during my program, I like to take a moment where we can all stand together as one community and really send out the positive vibes to everybody tonight who needs them. So to each of you out there who are feeling alone, who are feeling scared, to everyone who is sad and depressed, to everyone who is just blue or maybe anxious, worried about the future, not knowing what it will hold. This group of people here would give you the shirts off their backs to know that you're not alone. We are all in this together, my friends. Tomorrow is a new day and it is full of all new adventures. So there is hope. And that's what I say every day forward, with that hope, knowing that tomorrow brings us all new stuff. All the positive vibes out there to you, my friends, to everyone tonight who needs it, from everyone tonight who is here and willing to give it. Thank you for being a part of that 5:30 Fuzzies with Fink. That is how we break the internet with kindness. The kindness thing is really sort of a thank you for the hearts there. I appreciate seeing that. Never really know if people are hearing this or not, but it's really a message that I think is important. There's not enough kindness in our world. And so how can we change the world one person at a time? We can do that with just a little bit of kindness. And maybe that's a smile to a stranger. Maybe that's being nice to a child, doing something that a kid is going to remember. Maybe that's just being there for somebody who needs a shoulder to cry on or just an ear to be able to listen to them. That's what we can do to change this world. And so I encourage you all to embrace that. And thank you again for being a part of the Fuzzies with Fink. Hello, Zenaida in South Florida. Good afternoon or good evening to you. We've got M. Wonderland. We've got Brianna Ivani, I think is what that says. If you guys have questions, please throw them out my way, and I am happy to answer them. Since this is Pride Month, we started off talking about some of our options for the LGBTQ plus community. And I did get a question over here that asks about what is CMV and how is that relevant to my sperm donor? Okay, and that is a great question. So CMV stands for cytomegalovirus. Cytomegalovirus, and that's a viral illness that, to be honest, most of us have been exposed to at some point during our lives by the time we're adults. It's often a respiratory illness. It may feel like a flu that got to you, but it is something that if you contract during pregnancy can be devastating to a pregnancy. In fact, it is the most common cause of congenital deafness. The most common cause of congenital deafness, CMV, cytomegalovirus. Well, there is theoretically a risk when you are using a sperm donor that if you have never been exposed to the CMV virus, that is to say you are CMV negative, but that donor was CMV positive, there is a theoretical risk that the CMV virus can be transmitted on that sperm and can infect the egg from the moment of fertilization and create a CMV environment in that baby. Now, I say that is a theoretical concern because truthfully, when we wash sperm, most of the time that's removing CMV. When you're buying donor sperm, they generally check it to make sure there is no, they do a special DNA test called a PCR, usually that checks to make sure that there is no CMV virus. Nevertheless, if you are CMV negative, it means that you purchase a donor sperm that comes from a sperm that comes from a donor that is CMV negative. If you are CMV positive, which means that you are immune from CMV, that you've already been exposed to it, then it doesn't matter. It doesn't matter. You can get a CMV positive or a CMV negative donor because you're already positive, so negative isn't going to change anything at all. And that's that's kind of what that's about. So usually when you come for an initial consultation and we talk about kind of what's going on, when we learn that donor sperm is going to be part of your journey, CMV is one of the things that we will test. And that's the reason why. Now, what happens if, well, you say, they forgot to test my CMV, or I don't even want to know. I don't want to know for whatever reason. Then you just simply select a CMV negative donor, because if you're negative, then you need negative. If you're positive, you can use negative. It doesn't matter. Knowing that you're CMV positive only means that it opens the door to that many more potential donors, those that are CMV positive. So that's why it kind of pays to know. So hopefully that helps with that information. And a special good evening to Ob Fraley, as well as looks like One Min. I think that says One Min, Two Ann. I think that says. I think that's what that says. Hi, glad you're here tonight. Thanks for joining. And let's see, what else do we have here? Question about also about donor sperm. Which type of sperm should I purchase? Okay, and that's a great question too. So when we learn that you're going to use donor sperm, the first thing we want to know is we want to know about your CMV status. The second thing we want to know about is what sort of genetic diseases you may be a carrier of. So I call it the color of our genome is quite varied. It's quite colorful. That many of us carry. We are carriers of genetic diseases. In most cases, these are utterly irrelevant unless both you and the sperm donor, unless you, female, and sperm donor, whether that's a partner or whether a donor, happen to carry the same disease. And if you're both carriers for the same thing, it gives you a 1 in 4 chance of having an affected baby. And so obviously the time to find out about that is before you get pregnant, because we can actually prevent you from having an affected baby through the IVF process. So usually when you're going to pick a sperm donor, they have run this genetic carrier screening test on the donors and will list out the different things that they may or may not be that they may be positive for. So you just want to select a donor that doesn't have the same carrier status as you do. Now, as far as these genetic carrier things, some of them are things that are more common that we've heard of, things like cystic fibrosis, certain types of muscular dystrophy. Most of them, to be perfectly honest with you, are these much rarer diseases that some of them are what are called inborn errors of metabolism. They are little enzyme defects that can affect the way bodies develop and people grow, and they can be devastating. So I think it is definitely important to be able to test for that. But the question was, what about so those are the things that we want you to clear when you're selecting a donor. The other thing that these different sperm banks will offer is that they generally offer different levels of sperm that you can purchase. Each one is progressively more processed in the laboratory, and as a result of that extra processing, there is extra cost. And my advice, at least in my practice, is don't overspend on that. Get the cheapest one they offer, because we are going to prepare it in the lab anyway. And so at no additional cost. That's kind of part of what we do. So don't spend extra to buy a highly processed lab specimen when we're going to do that processing anyway. And I hope that makes some sense to you. Yeah, that's my 2 cents worth on purchasing that donor sperm. Let's see, was there anything else about donor sperm? What about sperm banks? Are sperm banks all reliable? Well, these sperm banks are all, fall under the auspices of the FDA. And so, yes, they are very reliable. The type of infectious disease testing that is required of these specimens and the amount of documentation that's required is very extensive. The government gets involved, and that makes it very extensive. So in general, yes, you can trust that the sperm that you get from the sperm banks is safe for you. I had the conversation today with a patient who was talking about gosh, but the problem is that you sit down and look at all these sperm donors, and you can very quickly go down this rabbit hole and be really lost in the woods of trying to make a decision. And the same thing holds true, kind of when it comes to donor eggs or donor sperm. The same thing, you have a lot of choices that are in front of you. And so I always tell people, the first thing to know is that you're not marrying this person, right? This person is not going to be moving into your home. You're not having a child with this person. This person was purely a donor of genetic material. Now, you may read a lot about them. You may learn a lot about their background. You may learn, they may have a personal statement that you can read. You may see a picture of them as a child. You may learn about their family history. You may try to decide Is this somebody that I would like? And I would encourage you, don't go there, because you don't need to like them. They are only providing genetic material. So the important things about that: skin tone, hair color, eye color, genetic background. Does their hair, is it straight or is it curly? Some things like that. But really, when it comes to what that's going to mean in terms of your child's personality, that personality is really driven by something that we call epigenetics. And you may have heard me talk about this before. Epigenetics is the series of little switches that can either be on or off in whatever order they may be. And there are a million little switches. And depending on their order, that programs things like, is your child going to be mechanical or artistic? If artistic, is your child going to color or sing? Is your child going to be a writer or an artist? Is your child going to be, all these, athletics? Is it going to be your child going to be an athlete or going to be one that enjoys, scholastic pursuits? They're not mutually exclusive, but still, all that stuff is really programmed by the environment in which the embryo grows. And that would be your uterus. So the genetics don't have as much to do with that as you may think. And when you consider that and know that every drop of that baby's blood is yours, because that baby is in your uterus, that tells you something there. It really does make a difference in terms of how what your baby is going to be like. So when it comes to choosing donors, I think that's an important consideration. That this doesn't have to be somebody that you'd want to go to the movies with. It is really just about hair color, skin tone, eye color, height, and maybe some genetic family history. A special shout out this evening to one of the finest ultrasound techs I know, and a wonderful person as well, just a great human being, and that is Marin. Good evening, Marin. Thank you for being here tonight, and thank you for working at New Life Fertility, where you bring smiles and joy to everyone every single day. That's what we try to do here, folks, and if you are just joining, we have about 15 minutes or so left. My name is Dr. Randy Fink, and I am a fertility gynecologist at New Life Fertility in Pensacola, Florida. We are part of the First Fertility Network, the renowned fertility network nationwide. We have offices here in Pensacola as well as in Mobile, Alabama, and Panama City. And I also work with the Missouri Center for Reproductive Medicine, MCRM, in St. Louis and in Tulsa. If thinking about having a baby is something that you're into right now, then you are in the right place. If you have questions, please throw them my way. And that is what we do here. We are here every Tuesday evening at 5 o'clock Gulf Coast time. That's Central time for the hour or so. And Marin's over here on this side, but Sheila says Marin is the best. So you hear that? How do you like that? How do you like that? A special hello this evening also to Katie in St. Louis at MCRM, who is also truly an expert in her field, and it is great to see you here as well. I will be at MCRM. Well, let's see. I think I'm going to be in Tulsa next week to do some embryo transfers. So if you are in that area, stop by to say hello next Tuesday and Wednesday, and then I will be at MCRM in July for egg retrievals for a few days. So hopefully we'll get to see you there as well. Let's see, another question I had here, and that is, how can you measure egg quality? Well, unfortunately, you really can't measure egg quality. We can measure egg quantity and approximate that by doing a blood test that's known as your AMH, or the anti-Mullerian hormone. So, women are born, and I always think of this as a little bit of a design flaw, and that is the sperm that comes out from the guy today was manufactured in his body 3 months ago. But every egg that you will ever have in a woman is there on the day you're born. So over the course of our lives, we lose those eggs to the process of aging. We lose some of that DNA, starts to become unstable just because it's been sitting there. So those are two good reasons that it gets harder and harder for us to have kids as we mature. Well, so egg quality is really referring to the stability of the DNA that's in the eggs. And that, unfortunately, is something that we cannot measure per se. The DNA quality or the egg quality is really related primarily to the date that is on your driver's license, and that is your birth date. So it is very, very much associated with age, and the kind of fall off we see of egg quality is very predictable, really based upon age. So that's kind of how I quote people until we get some genetic material under the microscope and try to fertilize those eggs. That's when sometimes we may see that things aren't as they seem, but most of the time, that egg quantity is something we can measure. How do we measure that? Well, there's two ways. One is that AMH hormone. And so what does that even mean? In most cases, you got millions of eggs that are sitting in your ovaries, millions of them. And they're microscopic, so we can't actually sit there and count them. Although if anyone could, Marin could, right? She could count 1 million eggs. Just saying. And if you can't, you better be able to by tomorrow. Can't count all those eggs, but every one of those little eggs is surrounded by some cells. The cells are called granulosa cells, but those cells secrete this hormone that's called anti-Mullerian hormone, or AMH. So the more eggs you have, the more of these cells you have, and the more of these cells you have, the more AMH you make. So we can measure it in your blood, and we plot it out on a little graph and see where you fall relative to other people who are your age. And that's kind of what we do with an AMH. Now, we also like to look at what's known as an antral follicle count, or an AFC. And what that means is that in the beginning of your menstrual cycle, your brain tells the ovaries, give me some eggs. And the ovary says, okay. And so it dips down into its well and it pulls up some little follicles. And a follicle, not like a hair follicle, a follicle is a little egg house. Literally, it's a little tiny sac of fluid with a microscopic egg in it. And under normal circumstances, those little follicles, they will fight with each other. And they do. They literally fight with each other biochemically in order for one of them to emerge as the dominant egg, or the one that's going to get released. And that's the one that you ovulate when you release an egg. But we can count that number of follicles at the beginning of the cycle, and that tells us also, generally speaking, about the relative health and well-being of your ovaries from a fertility standpoint. So those are two things that we look at really primarily when we're trying to decide, well, what kind of medications are we going to use to stimulate your ovaries in order to try to get you to produce some eggs? We look at the AMH and we look at the antral follicle count. Now, there are some other tests that are involved, and that's another question I have here. What are the blood tests that I need to do before I get to see the doctor? Well, usually we want to look at those hormone levels, and that includes something called an FSH and an estradiol, your LH hormone, and your progesterone. Those are kind of the most important female hormonal things. We look at your thyroid hormone. We look at your prolactin hormone. There are some infectious things that we like to look at. One, we want to see that you are immune from rubella, which is German measles, and varicella, which is chickenpox. And why is that? Well, if you contract either of those things during pregnancy, they can be very devastating on a pregnancy. And in fact, chickenpox in pregnancy is not just an itchy rash. There is a high prevalence of maternal death in pregnant women who contract chickenpox, and so that's kind of pretty important there. The MMR vaccine, measles, mumps, and rubella. I think you get your last. I keep meaning to look this up. I don't remember if you get it when you turn 18, but I think you're 4 years old. Kind of when you get the MMR. It's a non-controversial vaccine. It has been around for decades and decades. Is known to be a safe vaccine, really without any controversy whatsoever. So I encourage everybody to be rubella immune. But the chickenpox thing, I had chickenpox as a kid, nowadays kids are vaccinated for the chickenpox because it's a nuisance. It's highly, highly contagious. But really the biggest concern about the chickenpox thing, if you're thinking about getting pregnant and you find that you are varicella non-immune, I want you to think of it not as an annoying rash, but something that is potentially life-threatening to a pregnant woman and certainly also to the unborn baby. So both of these vaccines are easy to get. You get them from Walgreens or any pharmacy. It is a very easy thing to come upon to do. They're both live vaccines, so that means that you want to get that vaccine at least 30 days before you get pregnant. We don't like to do live vaccines in pregnant people. So 30 days beforehand, that gives you enough of an immune response. If you had been previously vaccinated for chickenpox, you only need one shot. If you've never been vaccinated, I believe it's a 2-shot series. Fraley says, are you testing for measles too? No, measles, fortunately, so now in Texas, of course, there's been the measles outbreak because of some current, political sorts of things. But really the bigger risk to pregnancy itself would be rubella. So rubella is the one that we test for. Now, if we find that you're rubella non-immune, it may also mean that your measles immunity has waned as well. But when you get that MMR, measles, mumps, and rubella, they're really 3 separate pathways. And so you can't always conclude that it's the same. But if I found I was rubella immune, I would certainly worry about the measles part as well. And that's a great question. Thank you so much for asking it there. So those are the kinds of blood tests. We like to do that genetic carrier screen. In my practice, we like to ask about some different autoimmune type things to see if maybe there's any sort of autoimmune issue going on with you. We check a blood count. We want to see that you're not anemic. And of course, in most places, we have to check an infectious disease panel, which includes HIV, hepatitis B, hepatitis C, and syphilis. Those are things that we want to know about because we can mitigate, we can impact the transmission, what's known as a vertical transmission of infections from mom to baby. And that is the way that works. I hope I've been able to answer some questions here for you. And I really want to say, especially thank you also for being here if you were at the bottom of the hour. That Fuzzies with Fink thing, to me is really important because knowing that there are other people out there who care about us is really changes the way that you look at life. And knowing that you have done something for someone, even if it's someone that you don't even know, may be enough to change your day as well, because that truly is how we make the world a better place. If you're dealing with this fertility business, it is not the book of your life. It is just a chapter. And what we are doing here, my friends, is trying to rewrite that chapter together. So every step forward with love every step forward with hope that tomorrow is a new day and full of all new adventures. Every step with kindness. So until next week, Dr. Randy Fink in Pensacola saying thanks so much for being here. And I'll see you next week from Tulsa. Good night.